Start recording. I got to give her my number so she can message me.
Yeah.
All this
Morning.
morning.
Hey, Elena. How
How
are
you
you?
Alrighty, so today's lecture, we're going to start getting into congenital heart defects. So just a little bit of information that you can keep in the back of your mind to help you with some of this congenital heart defect stuff. When we talked a little bit about before D-shaped left ventricle. So that's when we have our parasternal short axis view at the level of the papillary muscles, and we can see the right atria above it. And then we get that flattening of that that septal wall. So when we have a D-shaped left ventricle, so a pressure overload will cause D-shaped LV in both systole and diastole. And a volume overload B and only diastole. That'll help you with your boards and when you're taking and you're assessing these shunt lesions, whether if it's a pressure overload or a volume overload or both. So with congenital heart defects, they can be broken down into three categories. Three categories of CHD, congenital heart defects. So our first one's going to be a shunt lesions. Second one, it's going to be valvular. And great vessels. And our third are going to be complex lesions. We have shunt lesions, valvular and great vessel lesions, and complex lesions, which is going to be a combination of the two. That's going to, example of that would be our tetralogy of Fallot. I'm going to spend this class primarily focusing on our first one here, our shunt lesions. right, so some examples of shunt lesions. We have our ASDs, or atrial septal defects. VSDs. Ventricular septal defects. AV canal defects. Put under here as well, Eisenmenger syndrome. So under our shunt lesions, there are two kinds of congenital shunt lesions. First kind is going to be patency of normal fetal structures. That failed to close. That could be your PFO. And your PDA. And the second kind of shunt lesion is incomplete closure of septal structures during cardiac embryology. They're incomplete closure of septal structures during embryology. So when we're talking about shunt lesions, we have to remember that blood flows high pressure, to low pressure. And volume slash pressure overloads are affected Okay. Anatomical and vascular resistance to flow. So when I talk about anatomical resistance, that's essentially the size of the lesion, the opening. And then vascular resistance deals with the pressure against which, that blood flow has to go against. And with shunt lesions, there's an equation that we use to determine the severity of the lesions, and that is our QP to QS ratio. So Q is the volume of blood flow. P stands for pulmonic, so the pulmonic volume to the systemic volume. So QP to QS ratio equals flow volume P pulmonic systemic. You also have to remember that pulmonary hypertension lead to bidirectional or reverse shunting. We're going to talk a little bit later about that QP to QS ratio. Let's get into some of the different types of shunt lesions. We'll start with our atrial septal defects. ASD. So ASD is defined as a failure of the intraatrial septum to close during fetal development. Septum. Typically, blood flow is shunted from LA into RA. There's 4 types. NSDs. The ostium secundum ASD. Ostium secundum. Ostium secundum ASD. This one is the most common. 70%. Second most common is the ostium primum ASD. That makes up about 20% of ASD lesions. Third type of ASD is a sinus venosus ASD. This is about 8 to 10%. And the last one is a coronary sinus ASD. These are rare. Usually making up about less than 2%. So ASDs in general make up about 10% of all congenital heart defects. Make up about 10% of CHD, coronary heart defects, or congenital heart defects, sorry, congenital heart defects. So our ostium secundum ASD This is seen in middle of septum. Here. Fossa ovalis. Caused by either excessive reabsorption, septum primum, or deficient development of septum secundum. So if we have our apical or subcostal view, this shunt lesion you're going to see in the middle of the intraatrial septum. So our subcostal view is a good image of that. If we go back to our fetal embryonic development, so it could be either deficiency of the development of that septum secundum, so that second septum that was growing down during fetal development, or excessive reabsorption of that first septum, which was to develop. So on our fetal development, that septum primum started to develop and then gets reabsorbed, leaving the ostium secundum and the septum secundum. So with our secundum ASD, it's more common in females. At a ratio of about 2 to 1, twice as likely to occur in females. And commonly occurs in isolation. So meaning that it's not typically associated with other congenital heart defects. Commonly occurs in isolation. Another thing with secundum ASD. Patients more likely to have mitral valve prolapse. MVP. Primum ASD or ostium primum ASD. This one is located near AV valve. Lower portion of septum. So it's caused by endocardial cushion defects. And it could be considered a form of an AV canal defect form of canal defect. So primum ASDs are associated with inlet VSDs. Left anterior mitral valve leaflets. And Down syndrome. sinus venosus ASD. So this is seen at junction of right atria and superior vena cava. Most common posterior to the fossa ovalis. Junction of RA. SCC. Most common. Superior. This. This is going to be along the posterior portion of the atrial septum. This is associated with PAPVR. So PAPVR, that is partial anomalous pulmonary venous return. So what that is PAPVR. That's when a right pulmonary vein inserts into the right atria instead of the left atria. Right pulmonary vein inserts into RA. LA. So one of the right pulmonary veins now inserts into the right atria instead of the left atria. It's typically the right upper pulmonary vein. Last type of ASD is the coronary sinus ASD. like we said, that these are very rare. And these are located on the inferior to the fossa ovalis, where the coronary sinus enters the RA. Located on inferior septal inferior to fossa ovalis, where coronary sinus enters right atria. So one last thing that doesn't really fall into any of those four main types of ASDs, but something to also consider that could be a possibility would be a common atria. So that would be no septal development. Clinical presentation. So they'll have an asymptomatic murmur. Pulmonary flow, murmur from increased volume. You can potentially have a diastolic rumble from increased tricuspid valve flow. Splitting S2 heart sound. Right. RA. RV. Enlargement. And prominent pulmonary arteries. So hemodynamic effect depends on the size and direction of the shunt, the compliance of the ventricles, and the response of the pulmonary vascular bed to the increased blood flow. So after birth, the shunt is going to be from left to right. The increased flow to the right side of the heart causes elevation in the pulmonary vascular resistance. This could eventually lead to our Eisenmenger syndrome, where we get that reversal of flow, which means that the shunt will be directed from right to left, and this leads to cyanosis and heart failure. So for our ASDs, we use our subcostal window. Shunt begins in mid systole. Flow decreases. And then increases. Again, atrial contraction. We have increased flow volume across tricuspid and pulmonic valves. I'm gonna highlight this because this could potentially be a registry question that, we're talking about ASDs, hemodynamic significance is based on volume and not the size of the defect. Hemodynamic significance based on volume and not the size of defect. For pulmonary hypertension, will develop if not fixed. Because we're having right ventricular enlargement, that annulus on the pulmonic valve is also becoming stretched, which will result in pulmonary insufficiency and increasing the volume overload. So, because of RV enlargement, annulus is stretched, leading to PI, pulmonary insufficiency. So we measure defect diastole. A small defect. Less than 3 millimeters. With these, we have 100% spontaneous closure. By 18 months. So with the small defects, there's no repair needed. moderate. That's a defect from 3 to 5 millimeters. These have an 87% chance of closure. Large. 5 to 8 millimeters. These actually have an 80% chance of closure. And then lesions greater than 8 millimeters. Will not spontaneously close. So that 8 millimeters for your lesion size is your magic number, your magic cutoff point. So under 8 millimeters, you have a pretty good chance of that lesion closing up spontaneously on its own. But once you get over 8 millimeters, that's when surgical intervention is required. Hello. Another thing to remember, smaller defects greater pressure gradients. So if you stop and think about that statement for a second, the smaller the hole, the smaller the defect, the higher the pressure gradient is going to be between the two chambers. So when you have a higher pressure gradient, you're going to have faster blood flow. So the sound of the murmur is going to be a lot more, it's going to be a lot stronger with a smaller defect. So with my daughter, when she was born, she had a small VSD. And I remember the pediatrician was like, oh, this is like, grade 4, VSD, like murmur. They were describing the sound of the murmur as a grade 4, which was really high. And in my mind, I'm going, oh my God, like that sounds terrible. And then I had to like pause for a moment. I was like, oh, wait a minute. Like, actually, that just means it's a very small hole. The louder the sound, the smaller the hole. Because the smaller the hole, the larger the pressure gradient, the faster those velocities through the defect, the more turbulent sound or the more turbulent the blood flow is going to be because of those higher velocities. So with larger defects, pressures will equalize more quickly. Will equalize more quickly. So if we're scanning an adult patient and we happen to find an ASD, say it was something that went undiagnosed into their adulthood. If adult patient. We also want to look for left mitral valve. We look for our partial anomalous pulmonary venous return. So that's that pulmonary vein in the right atria. We'll also look for a PDA, patent ductus arteriosus. And we'll also assess to make sure that there's no sign of a VSD. Well, we're also, if it's an adult patient, we're gonna measure right ventricular pressure. Pressure. And pulmonary artery pressure. And then we're also going to measure the gradient across the shunt. Now we're going to just talk a little bit about that QP to QS ratio. QP, QS. We said before, Q stands for volume. The P is pulmonary. And S is systemic. So this is right side of the heart, left side of the heart. So this is essentially the stroke volume. At pulmonic valve to stroke volume. Aortic valve. So normally, ratio 1:1. But what goes into the right side of the heart is going to leave the left side of the heart. What goes through the right side goes through the left side. So the way this QPQS formula works, it's going to be our pulmonic valve, VTI, times pulmonic valve area divided by aortic valve, VTI, times aortic valve area. QP to QS ratio greater than 1.5, abnormal. So that's showing that the flow volume through the right side of the heart is about 1.5 times greater than flow volume through the left side of the heart. So we have more blood flow going through the right side of the heart than we do the left side of the heart.
Dan, I have a question. In the congenital heart defect PowerPoint, it says greater than 1. Should we go off of the 1.5 and not the 1?
So the 1.5 indicates that that it's an abnormal, well, it means that it's clinically significant, like it's a significant amount of, the lesion is significant enough to cause issues. So normally the ratio should be 1 to 1.
Okay.
Anything greater than 1 would mean blood flow is shunting to the right side of the heart. A ratio of 1.5 would be, we'll put clinically significant.
Okay.
It's better, right? Clinically. So if it's a ratio that's less than 1, that means we have a left to right, I'm sorry, a right to left shunt. So blood flow is going the opposite way. So QP to QS ratio greater than 2. Will lead elevated pulmonary artery pressure and needs repair. QP to QS ratio is less than 1 indicates right to left shunt. Again, our Eisenmenger syndrome. It's going to be any left to right shunt, which becomes a right to left shunt. So any left to right shunt, which becomes a right to left shunt, or bidirectional. To elevated pulmonary artery pressure. So Eisenmenger syndrome is any left to right shunt that becomes a right to left shunt or a bidirectional shunt due to elevated pulmonary vascular resistance or elevated pulmonary pressure, pulmonary hypertension. You could put all those words in there. So pulmonary artery pressure, pulmonary hypertension, pulmonary vascular resistance. So best views for ASDs. The secundum. It's going to be our subcostal long and short axis views. Apical four-chamber and parasternal short axis. Our primum ASD. Our apical four-chamber and our subcostal long and short. Our best views for our partial anomalous pulmonary venous return. Best view for our PAPVR. This is actually something called a suprasternal notch crab view. So with that crab view, we're able to visualize the 4 pulmonary veins entering LA. So this is a view that's typically done in a pediatric echo lab. So with ASDs, we want to assess the location and the relationship to the aortic valve. We want to assess pulmonary venous drainage. We want to assess the hemodynamic consequences and estimate the size of the ASD and look for any associated anomalies. Any questions about ASDs? We really want to determine, that QP-QS ratio. Look for any signs of hemodynamic compromise by measuring the pressures in the right ventricle and in the pulmonary artery. We're assessing for signs, pulmonary hypertension, increased pressures in the pulmonary artery, pulmonary vascular congestion, because that's going to be, our driving factor as to whether or not we have to repair this ASD. And then ASDs over 8 millimeters need surgical repair. And then most common ASD is going to be our secundum, followed by our primum ASD. It's the second most common. We do ASDs. So ASDs can be repaired using an occluder device. So an occluder device, it looks like kind of like this little umbrella that's fed through a catheter. So they insert the catheter into the actual ASD, and they open up this device that looks like a little umbrella. So if I had to draw an occluder device, you have your little catheter. They place it into the hole in the ASD, and then they open up the catheter, and it opens this device that kind of looks like an umbrella. And then they remove the catheter, and that device then plugs and closes up that ASD. And then eventually over time, the septum is going to grow over that occluder device and fuse with the septum. they're closed using an includer device. I'm going to talk about VSDs. Guys want to take like 5 minutes before we get into VSDs? We'll break.
I mean, I'm gonna run to the bathroom, but you can keep going if you want.
All right. All right, so VSDs. So this is communications. Between ventricles. To closure or due to failure. Closure. Yes, the intraventricular septum. During fetal development. So VSDs make up about 15 to 23% of congenital heart defects. So, an isolated VSD is the second most common congenital heart defect. Anyone want to guess what the most common is? The most common is actually a bicuspid aortic valve. Most common congenital heart defect is bicuspid aortic valve. And VSDs are the most common defect in chromosomal syndromes. Most common defect. Chromosomal. Chromosomal syndromes. So those are like your trisomies, trisomy 21, trisomy 13, Down syndrome. So types of VSDs. So when we talk about types of VSDs, we have to remember that the intraventricular septum is broken up into, or consists of a muscular septum and then a membranous fibrous septum. The types of VSDs. So IVS consists a muscular and membranous segments. So muscular septum. Has several subdivisions. Under the muscular septum, we have the inlet septum. This is actually ventricular inflow. This is the portion of the septum that's near the ventricular inflow. Another subdivision of the muscular septum is going to be our trabecular septum. So that is the mid portion. And then the third subdivision is the outflow septum. And this is associated with the areas of the outflow tracts. membranous septum. Is formed the inferior endocardial cushions. Tissues of the inferior endocardial cushions. So this first type of VSD is called a membranous VSD. When I learned it, it was called a perimembranous VSD. Types of VSDs, you have membranous. Put it out here, perimembranous. In case you come across that in your reading or your literature, or if you're in a lab that calls it a perimembranous, they both mean the same thing. So membranous VSD. This is going to be your most common. It makes up about 75 to 80% VSDs. Located in the membranous septum. Just below LVOT, and the aortic valve. Another term we could potentially put here is infracrystal. Small membranous VSDs can close during childhood. something that can actually happen is the tricuspid valve leaflet can bulge into space and close VSD. If closure is incomplete, a small defect remains. Our second type of VSD is going to be a muscular VSD. So these are found in body of ventricular septum. Can be isolated or multiple. So the term, if the patient has multiple muscular VSDs, it's actually called a Swiss cheese defect. And I think of the big muscular septum with lots of little holes in it. Kind of looks almost like a piece of Swiss cheese with the little holes. So the next type of ventricular septal defect is an inlet VSD. So number 3. Inlet VSD. So this can also be considered an endocardial pushing defect or AV canal defect. And these result from incomplete formation of the central fibrous body. Results. Incomplete formation central fibrous body. They're located inferior to the aortic valve plane. So, let's see. Located inferior to aortic valve plane. Posterior to the cuspid valve / mitral valve annulus. So this is along inlet portion of the ventricular septum. They're associated with other endocardial cushion defects. Endocardial cushion defects. So some examples of that would be primum ASD, complete AV canal defect, AV valve defects, and Down syndrome. So associated with other endocardial Cushing defects like your primum ASD, complete AV canal defect, AV valve defects, and Down syndrome. Inlet VSD may also result in a left ventricular to right atrial shunt. May result in a left ventricular to right atrial shunt. Well, typically seen in apical four-chamber when AV valves are in view. So we typically see this in our apical four-chamber when we see the mitral and tricuspid valves. So next VSD we can have is an outflow VSD. Outflow can also be called an outlet VSD. So outflow VSD or an outlet VSD. Some other terms that you may hear associated with that could potentially be a supracrystal VSD, supra. Crystal. Or infundibular. On tubular. So these are located RVOT. Carrier to pulmonic aortic valves. Um, These are rarely seen in adults. More common in Asian population. They're commonly associated with AI or aortic insufficiency. Secondary to the prolapse of right coronary cusp. So I learned a fifth type of VSD called a malalignment VSD. Malalignment VSD. This is a defect between the outlet and trabecular septum. Outlet and trabecular septum. Malalignment VSD, aorta, pulmonary artery, override, intraventricular septum, V valves. Are malaligned. So this is common with tetralogy of flow. And truncus arteriosus. Arteriosus. So truncus arteriosus, that's when we have one trunk draining both ventricles. So one main vessel. So VSDs are commonly associated with pulmonary atresia. Yeah.
Did you say atresia?
Yeah, atresia. So under development of the pulmonary artery. So the same holds true with VSDs as with ASDs. So the smaller the VSD, the greater the gradient across the defect. Smaller VSD, greater pressure gradient. Across. We measure our pressure gradients using our pressure half time. So blood goes from LV, RV, during systole. And goes directly into pulmonary artery. So main pulmonary artery. Left side of heart. See biggest increases blood volume. So if the pulmonary artery and the left side of the heart are seeing the biggest increases in blood volume, we could expect to see pulmonary vascular congestion. Left side of the heart, we have volume overload. We expect to see left atrial dilatation, left ventricular dilatation. We see LA and LV. Dilatation. Pulmonary hypertension. Increased LA pressure. So because the blood is getting shunted over during systole and the pulmonic valve is open, we typically don't get the same kind of volume overload on the right side of the heart. So we don't typically see right ventricular dilatation with a VSD, which is kind of counterintuitive. You think blood flow is shunting from the left ventricle to right ventricle, you now have all this extra volume on the right side of the heart. But because it's during systole and that pulmonic valve is open, the blood flow is immediately getting shunted into the pulmonary artery, which leads to your pulmonary hypertension. So as opposed to seeing right ventricular dilatation, we can actually see right ventricular hypertrophy. So with pulmonary hypertension, we see RVH, right ventricular hypertrophy. And pulmonary hypertension. And to Eisenmenger syndrome. When these patients and these kids or babies develop Eisenmenger syndrome, they wind up becoming cyanotic. So if that VSD or even ASD went unnoticed, and that patient now starts developing Eisenmenger syndrome, they're going to immediately become cyanotic. And then you'll know something's up. Another way to describe VSDs is as restrictive or non-restrictive. Restrictive versus non-restrictive. Lesion. Restrictive VSD. We have RV, right ventricular pressure. Is less than left ventricular pressure. This is going to lead to a left to right shunt, left to right shunt. And this is seen with small defects. So a non-restricted VSD RV pressure is greater than or equal to, because remember, you can also have a bidirectional shunt. RV pressure is greater than or equal to LV pressure. And this leads to a bidirectional or right to left shunt. And these are associated with large / multiple VSDs.
Dan, can you please move a camera a little bit to the right? Yes, thank you.
So non-restrictive lesion or a non-restrictive VSD, right ventricular pressure is greater than or equal to the left ventricular pressure. That results in either a bidirectional or right to left shunt. These are seen with larger VSDs or the presence of multiple VSDs. A restrictive VSD, the right ventricular pressure is less than your left ventricular pressure. So you have your normal left to right shunt, and these are seen with small defects. So some clinical presentations for our ventricular septal defects. Presentation. We have a harsh solo systolic murmur. Dilated pulmonary vessels. That's going to be both your pulmonary artery and pulmonary veins. Now you have a lot of blood flow being shunted across the septum into the right ventricle, directly into the pulmonary artery. So it's going to dilate the pulmonary artery, as well as dilate the pulmonary veins, because you now have increased blood flow into the lungs. So the veins are going to dilate as well. You now have a volume overload, that blood flow circulating back. So dilated LA and LV. So dilated LA and LV, depending on shunt direction. Shunt direction. So on echo, we're gonna identify size and location. Lesion. Use color and CW continuous wave to assess direction. Pressure gradient. Try and estimate V pressure. So to estimate RV pressure, we're going to use a formula. It's going to be 4V squared. And the velocity that we're measuring is the velocity across the defect. So V is velocity across defect. So 4V squared minus systolic blood pressure. Subtract from the systolic blood pressure. We can also perform bubble studies. Studies. We have our agitated saline. Enters right side of heart. So large micro bubbles. Are absorbed by the lungs. Don't make it to left side of heart. So if right atrial pressure briefly exceeds left atrial pressure, bubbles are able to pass through ESD. So again, we would have the patient's Valsalva and try and image those bubbles passing across the atrial septum through the ASD. Actually, I forgot to mention, I had this back on VSD under your notes. So VSDs are usually repaired with a patch. Usually repaired with a patch. For ASDs, they use that occluder device, where there's VSDs, they typically repair it with a patch. See how long this section is. Another congenital heart defect now. I'm just going to talk a little bit about coarctation. Coarctation of the aorta. So we know that this is a narrowing, an abnormal narrowing or partial obstruction of the distal section of the descending thoracic aorta. So coarctation of aorta is a partial narrowing or occlusion segment descending aorta. So the majority of them are going to happen just past where the left subclavian comes off the arch. Location. The most common location is going to be just distal to the branch of the left subclavian off the arch. This is where you get your narrowing. So the most majority occur near or just distal to the left subclavian artery, near the ligamentum arteriosum. Most occur subclavian. So they account for 10% of all congenital heart defects. Congenital heart defects. They're typically associated with other congenital lesions such as bicuspid aortic valve and a ventricular septal defect associated with bicuspid aortic valve and ESD. So increased pulsation of the aorta may be seen proximal to the lesion, along with increased diameter of the left subclavian artery. Poststenotic dilatation may be present as well. You may also develop collateral vessels to help provide blood flow to the extremities. So, let me see. Post-stenotic dilatation. Let me see. Collateral vessel development. To provide blood flow to lower extremities. So the upper extremities are okay in terms of blood flow and blood supply, because that coarctation happens typically past the level of the left subclavian. So the right arm is okay because that's getting fed by the innominate. Left arm is okay because it's getting fed by the left subclavian, but the lower extremities now are starving for blood. So that's why you may wind up with the collateral vessel development to provide blood flow for the lower extremities. That could potentially come into play as well if we're doing an ABI PVR and we see potentially low pressures, throughout the lower extremities, and it's a young patient, not too old. You don't suspect them to have, major occlusive disease, aortoiliac disease. The potential diagnosis could be a coarctation based on the patient's age. So their extremity pressures are fine, but their leg pressures are low, All right, so then we'll just, I'll do tetralogy of flow, and I think that's, that'll be enough for today. So one of the graduating seniors, Reese, has a nephew who actually has tetralogy of flow, and I actually got to meet him during the graduation ceremony. Little boy, he's cute. So tetralogy of flow. So there are four lesions that consist or make up tetralogy of flow. It consists of four lesions. The first one is a large overriding aorta. Next is a malalignment VSD. The next one is pulmonic stenosis or pulmonary stenosis. Pulmonic stenosis. If you have pulmonic stenosis, we're going to have RVH. Or right ventricular hypertrophy. So this is the most common cyanotic lesion in which survival into adulthood is expected. You actually have pretty good outcome with patients with tetralogy of flow, but the surgeries involved are quite extensive. Most common cyanotic lesion where patients survive adulthood. Again, this one makes up about 10% of all congenital heart defects. It's actually more common than you'd think. There are several factors that will determine the severity of symptoms. Severity of symptoms. Size of ESD. Degree of pulmonic stenosis. And position of aorta. So RVH and obstruction of the pulmonary at the pulmonary level can cause VSD to shunt right to left. And this produces a decrease in the systemic arterial oxygen saturation, cyanosis, and reduced pulmonary blood flow, and possibly a hypoplastic or decreased size of the pulmonary artery. I'll break that statement down a little bit. So RVH and obstruction pulmonary and obstruction at pulmonary was ESD. To shunt. Right to left. Which leads to cyanosis. And possibly hypoplastic pulmonary artery. Any questions about anything so far? I think that's pretty good before we start getting into like D looping and L looping and all that stuff.
Think I can go today?
So just remember, always keep in the back of your mind, is it a pressure overload or is it a volume overload? Are we talking about pressure or are we talking about volume? And then understanding the heart's response to pressure versus volume. So volume overload, heart's response is going to be dilatation. We're talking about the ventricles with volume, they're going to dilate first and then hypertrophy. If it's a pressure overload, the ventricle's response is going to be hypertrophy followed by dilatation. General rule of thumb, atria don't hypertrophy, they just dilate. So atria's response to both pressure and volume overloads are going to be dilatation. Kind of wrapping your head around that, you can really break down and break apart a lot of these registry questions. That and understanding when the valves are open and when they're closed, determining which type of murmur or what's causing the potential murmur. That was another big registry thing that they had. And they told me go through the cardiac cycle with you, like the EKG stuff too, and brush up on that. We'll get into that a little bit at the end of the summer, just so you guys feel comfortable and ready. I don't want you to forget any of this stuff come this next spring. Any questions about this so far? We're good. See you guys all a little later.
Yeah, what time are we planning on?
You guys decide amongst yourselves. I'm here. I'm not going nowhere.
Okay.
There's some of the DMS girls are here now, actually, too.
Okay. Kristen wanted to know if she comes in today and does scanning applications with us, does she have to come in Wednesday too?
I don't know. Should I do that?
I don't know.